we not fear the dizzy patient? Well, I will give you 4 basic questions, and at the end of the 4 basic questions, the purpose is to ensure that the physicians don't die prematurely, because many of us get very stressed when we see patients with dizziness. As you know, stress leads to shortening of life. So what are the 4 basic questions? First question is the person's dizziness vertiginous in nature or syncopal in nature? Okay. So when we refer to vertigo, we are referring to an illusion of movement. So patients will refer to a subjective feeling of movement and almost always associated with nausea and vomiting. On the other hand, syncopal dizziness is characterized by transient hypoperfusion of the brain. So if there's transient hypoperfusion of the brain, so the feeling that you get is not so much movement, but is obtundation of your sensorium. You feel like you're losing touch with the surrounding, voice is getting distant, vision is getting blurred, and if it persists, you're likely to faint. So let's get that part of the equation out for the first part of the discussion. If the patient says, "Doctor, I'm feeling syncopal dizziness," I basically ask 4 or 5 questions that have fundamental basis in the pathophysiology. If you think about it, why should anyone get transient hypoperfusion of the brain? It could be related to the source itself. The source is the heart. So what can happen in the heart? Well, 2 things can happen. The rhythm can fail, either in terms of a heart block or ventricular tachyarrhythmia, so that transiently blood is not flowing to the brain, or the flow can be blocked. For example, in young patients with Hockham or in older patients with aortic stenosis. So when they exert themselves, there is flow blockage and the patient feels transient obscuration of vision, transient obtundation of vision, and they can complain to you of a syncopal dizziness, and if that persists, they can actually faint. Now, if the heart itself is normal, then what else can be wrong? Maybe it is the blood itself that's coming from the heart that is abnormal. So things like anemia, especially if it's acute anemia, hyponatremia, hypoglycemia, hypercalcemia, and in the older patients you can actually extend it to even sepsis and many other drug-related problems that can cause patients to come to you and say they feel lightheaded and they feel very syncopal. Now, if the heart is normal and if the blood is normal, perhaps it is not so much the blood itself, but the pressure that's being transmitted to the brain is abnormal. So this can be either transient, as in postural hypotension, or it can be persistent, as in patients who are overtreated with blood pressure medications. Now, most of the time it is transient, so postural hypotension. So patients will complain of dizziness when they stand, dizziness after meals, dizziness after exercise because of postural hypotension, and it can be due to either issues with the endocrine system like hypocortisolism, or it can be related to drugs, or it could be an underlying autonomic dysfunction. Now, if we have sorted out the heart, if we have sorted out the blood, and we have sorted out the blood pressure, the only thing left behind is the blood vessels. But fortunately for us, we have 4 blood vessels going to the brain with communication called the circle of Willis. So more often than not, when there is problems in the blood vessels, they don't present with syncopal dizziness, but they present with a TIA, transient ischemic focal neurological deficits. So it's very rare that patients with vessel problems present to you with syncopal dizziness, although occasionally we see patients with basilar artery disease presenting with sudden loss of consciousness. And then finally, if you think that the blood pressure is normal, blood is normal, the blood pump is normal, the blood vessels are normal, then perhaps it is a physiological phenomenon of vasovagal syncope. Now that is a common cause of syncopal dizziness in young patients who, after a noxious stimulus in an erect position, they feel lightheaded, and if they persist, they are going to faint. Now this is believed to be a phylogenetic atavistic remnant of the playdate phenomenon that is seen in animals. And it's not really a disease, and many of us see that as a common problem in young patients who come to us with recurrent syncope. Now, if let's say the patient says, "Doctor, no, I'm not feeling transient obscuration of vision, I'm not feeling transient obtundation of sensorium. I'm actually feeling things are moving around me. They are moving around me very fast, like spinning, or they are moving around like a tilt. And during this period, I'm feeling very nauseous and I'm vomiting all over. This is consistent with a symptom of vertigo. Okay? So once you've established that the patient's problem is vertigo, then there are three other questions you have to ask. Is the vertigo associated with any CNS features like double vision, numbness of the face, weakness of the face, slurring of speech, weakness of the limbs, or numbness of the limbs? The next question you need to ask is this the first episode or is it recurrent in nature? And the last question is the duration of the spell. Does it last few seconds, few minutes, or very long? Okay? Rather than talk theoretically, I'm going to straight away plunge into some cases. So, the first patient is coming to you and says, Doctor, I'm very dizzy. So you calm yourself down and then you continue to ask the patient, what do you mean by dizzy? Then the patient says, no, actually, I am feeling things moving around me a lot. Everything is spinning very fast. Sometimes I feel like I'm tilting to the side and I'm feeling very nauseous. In fact, can you see this? I've got this vomit filled back because on the way to your clinic, I was vomiting all the way. So this is clearly vertigo. Okay? Then the next question is, do you have CNS features? Yes, doctor. While I was doing this, on the way here, I had double vision and my right side of the body wasn't moving very well. This is the first episode ever and it lasted a few hours. Now, what is this? Clearly, this is a posterior circulation stroke. So what do? We put the patient into an ambulance and send the patient to the emergency department. So it's very clear-cut, right? But rarely do patients come to you with such clear-cut history. Most of the time, they come to you with a story like this, which is, Doctor, I'm spinning all over and I'm vomiting all over you. But I don't have any double vision. I don't have any facial asymmetry. I don't have any facial numbness. I don't have any dysarthria. I don't have any dysphagia. And my limbs are fine. I don't have any numbness or weakness of the limbs. So in other words, the second question is unanswered. Then they tell you, Doctor, this is the first episode ever in my life. First episode ever in my life. I never had anything like this. And I can swear every bit of money in my bank that there is nothing like this ever in my life. And it's been lasting many, many hours. So this morning at 10 o'clock after breakfast it started. Now it's 3 p.m. and it's been continuous, unremitting. Okay, so what is this? Now, when given this question to many doctors, a lot of them will say the absence of CNS features here will suggest this is peripheral. But that is actually a cognitive bias. Because the absence of CNS features does not mean that this is not a central nervous system disease. So in this particular case, the absence of finding is not as useful as the presence of finding. So this brings me on to the next question, which is, does my patient have a stroke? And this is what has been coming around for the last 10 years in the realm of stroke neurology as well as neurotology. Somebody who presents with this story could have an acute vestibular neuronitis, which is super benign, meaning that the patient could be vomiting all over you, could be very sick, could be miserable, but nothing will happen to the patient. She or he is going to lead a normal life for the rest of his life, right? But if we mistake this to be a vestibular neuronitis when it's actually a cerebellar stroke, the patient could result in either a bad outcome or worse still, a bad outcome for us in terms of our license, right? We may lose our license from this. So this is what I call a license or limb-threatening situation, okay? So you don't want to lose our license, okay? Of course, we don't want to lose our patients too. So therefore, it's very important to sort out between these two diagnoses. Now, there's nothing in this story that tells you whether this is vestibular neuronitis or stroke. Now again, Dr. Manji is here, so tomorrow he'll talk to you about some of the biases that we have. When we see a young patient, we say, oh, young patients, no vascular risk factors. This could be vestibular neuronitis. But we know that young patients can get a stroke. In fact, it is much more dangerous for us to miss a young stroke with all its consequences than in a 90-year-old patient who many of us may feel, or maybe it's a 90-year-old patient, it's okay for the patient to get a stroke. So using the age and risk factors is useful, but it's not going to protect you from life or limb-threatening consequences. So you need something more objective, and that is what people have done in this area. There's quite a number of doctors working on this, and they've come up with this clinical acronym called HINTS, which is very useful to try to differentiate objectively without being too biased by the age of the patient or the comorbidities, but by using objective markers. What are the objective markers? HINTS stands for head impulse, nystagmus type, and skew deviation. Now, so what does this mean? So, if the patient's head impulse is positive, and the nystagmus is of a peripheral nature, and the skew deviation is absent, you can be more than 99% certain that this is not a stroke and this is vestibular neuronitis. On the other hand, if you have a head impulse negative, nystagmus is of a central nature, and if there's a skew deviation, the amazing thing is, even if the MRI is negative, this patient has a stroke. This patient has a stroke. Okay? These are the few instances where the clinical medicine easily supplants investigations. Okay? So studies have clearly shown that if your hints points towards a central cause, the absence of a finding on a scan is not useful at all. This patient still needs to be admitted for evaluation because the first scan may be normal for various reasons. Either the scans, the cuts were done too far apart, or the lesion was too acute and the patient wasn't seen, or the radiologist or the clinician was biased in looking at the wrong spot on the MRI. Okay, and another day when I have more time, I can show you very good cases that illustrate this principle. The HINTS is more sensitive than the MRI in picking up stroke. Okay, so what is the constituents of the HINTS? What is head impulse? Head impulse is what this lady has. So firstly, I put the patient in front of me and I'm moving the head very slowly to make her comfortable. Then I'm going to move the head very fast and I see whether there is a break in her saccades. You can see that when I move to the abnormal side, her saccade is broken. In other words, she looks away, she looks towards her head, and then she catches up. This catch-up saccade suggests that the vestibular function is reduced on that side. So in other words, if you look at me now, okay, while I'm looking at you, my head is moving very fast, but my eyes are still fixated where it's supposed to be fixated. But if I move to the abnormal side now, for example, if I move to the right, I'm normal. I move to the left. If my eyes follow the head, and then subsequently they catch up, that means this ear is not functioning. That is a positive head impulse test. It means peripheral hyperfunction of the vestibular system. Okay, let's play it again. So the first part is just to make the patient comfortable with the head movement. The second part, I move the head very fast from a central position and see whether a gaze is broken. To the abnormal side, a gaze is broken. Okay, this suggests that the left side is hypofunctioning in this patient. So that is a positive head impulse. Now that you've all been trained, let's see whether you can pick up where this patient's problem is. To the left, and to the right. So it's abnormal to the right. So this patient has got peripheral acute vestibulopathy on the right ear. Head impulse is positive. What about this patient? Much more difficult. So it's very subtle, but if you were to move it to the right, to the left is normal, to the right she just loses her vision for a while. So her right is abnormal. So if you want to know more about this and also tricks, how to improve your head impulse testing, please come back for the next episode, just like Netflix. We always give you a trailer for the next episode. So please come back for the next episode tomorrow morning at 7 a.m. when we will be talking about head impulse as one of the various dishes that we will be giving out for breakfast tomorrow. Okay, what's the next component of the HINTS? Nystagmus. Nystagmus, that's peripheral in nature. So what is peripheral nystagmus? Okay? Before peripheral nystagmus, maybe I talk about central nystagmus. What is central nystagmus? Well, central nystagmus is horizontal gaze evoked, downbeat, upbeat, pure torsional, or pendular in nature. Now, this is a lousy slide. You know why? Because it's a laundry list for you to memorize. And you will forget this tomorrow. So, what I would suggest is, enjoy it now. This is gaze evoked nystagmus. This is downbeat nystagmus. This is upbeat nystagmus. This is torsional nystagmus. And this is pendular nystagmus. All of them are central in nature. And again, if you want to remember the beauty of this nystagmus and how it's all elicited, come back tomorrow morning for this particular dish called Wong Bao. Wong Bao is my short form for gaze-evoked nystagmus and all the central forms of nystagmus. Okay? So, what is peripheral nystagmus then? Peripheral nystagmus, as opposed to central nystagmus, is unidirectional, fast ways away from the site of pathology, is mixed horizontal rotatory, and it's worse on looking away from the site of pathology, and it worsens when you remove visual fixation. Now, I'm going to explain the physiology of this so that you don't remember this by heart, but by logic. So what's the logic of it? So while looking at you, I'm always fixated on you because of the vestibulo-ocular reflex. And what is the vestibulo-ocular reflex based on? It's based on three semicircular canals: superior, horizontal, and posterior. I've enlarged it for the purpose of illustration here. Okay, so this is my three semicircular canals in my mastoid bone here, and this is my other three on this side. Now they are filled with water, they are filled with fluid. Okay, when they move, they're going to move the hair cells. So now when I'm looking at Dr. Say, for example, I'm moving my head to the left, my right eye automatically abducted and my left eye automatically adducted. Okay, that's because the impulse is picked up by my left semicircular canals, because the fluid is moving in this direction. It's picked up by my left semicircular canals and sent to the opposite 6 nucleus for the right eye to abduct and the left eye to adduct. Now if I would turn my head to the opposite direction, my right semicircular canals are picking up the signal and it's making my left eye abduct and right eye adduct. Okay? Now, while I'm looking straight at Dr. Say now, both sides are equally hypofunctioning, meaning they are equally at rest. But they are not dead. They are not dead. They are still functioning, but they are at resting position. So my eyes are steady. But if I come along and acutely damage my left vestibular system, as in acute vestibular neuritis, what's going to happen? Remember, these two sides were firing equally, but at rest. Now this guy is now completely dead because of vestibular neuritis. This guy is firing at baseline. So what's going to happen? It's going to look like my head has just turned to the right. But my head is not turning to the right. But my eyes are going to behave as if my head turned to the right. So my eyes are going to move towards the left side. And because I'm alert and active and I want to look at Dr. Say, not at the door, what am I going to do? Bring it back. But once I bring it back, the imbalance is still there. The eyes are going to drift back to the left. And then what happens next? Come back again. Okay, drift back to the left, bring it back again. Drift back to the left, bring it back again. What is this? Slow phase, fast phase. Slow phase, fast phase. And the fast phase is away from the site of disease. Rule number 1. Unidirectional and away from the site of disease. Why is it unidirectional? Does it matter whether I look up, look down, look right, or look left? No, because the imbalance is the same. So no business to change direction. Unidirectional, away from the site of pathology, and mixed horizontal rotatory. Again, we can figure it out without memorizing. One horizontal canal, one superior canal, one posterior canal. Right? This side is the same, right? And these 3 are dead. Now these 3 guys are alive. Right? Now, but this guy is completely unopposed. Right? But these 2 chaps, one is going up, one is going sideways. Right? Now, if he was going up and this one was going down, these 2 would have cancelled out. And he would have gotten a pure horizontal nystagmus. But unfortunately, this guy goes up slightly tilted to this backwards, and this guy is slightly tilted up. So therefore, these 2 guys don't cancel themselves off completely. So some of their vectors are added on to the horizontal nystagmus. That's why you get a mostly horizontal, but a hint of rotational nystagmus. So you can figure out all of peripheral nystagmus without memorizing this list by just doing this vestibular dance. The last one is Bromberg sign of the eye. So you all learned in neurology that when somebody comes to you and says, doctor, I'm very unsteady, but they are looking very fine. They are looking very fine. What do? We close the eyes. When they close the eyes, what happens? The patient falls, right? That's due to peripheral imbalance, right? So likewise, if there is a peripheral nystagmus, the eyes will be suppressed by a cerebellar system. The nystagmus will be suppressed by a cerebellar system. So when you close the eyes, what will happen then? Let's see. This man has got a typical mixed horizontal rotatory nystagmus. When he looks to the right, it beats to the right. When he looks to the left, it does not change direction. It's mixed horizontal rotatory. And in a few seconds, you will see the magic of closing the eyes. And his nystagmus becomes much more obvious. So this illustrates that this nystagmus must be peripheral in nature. But the problem is when the patient closes his eyes, you can't see his eyes. So what do you need? You need something like this. You need thick glasses, called Frenzel glasses, okay, which will remove visual fixation. And you can see the nystagmus disappears the moment she lifts up the glasses and she looks through her eyes. The moment I put on the glasses and remove visual fixation, and nystagmus gets worse. So, in summary, peripheral nystagmus is all of this, and it can be worked out very simply. Finally, skew deviation. What is skew deviation? It is vertical deviation of the eye. Vertical deviation of the eye. So, if you have a patient with head impulse negative, skew deviation absent, skew deviation present, sorry, and the nystagmus is central in nature, this patient has a stroke syndrome, whatever the MRI shows. On the other hand, if the head impulse is positive, skew deviation is negative, and the nystagmus is peripheral in nature, then this acute vestibular syndrome is peripheral in nature. Okay, next question, very quickly, the last few scenarios. If a person complains of vertigo, okay, but has got no central or peripheral features, but this time the patient says, doctor, this has been going on for months. It's not the new thing, and each spell is very short. Then there are two possibilities. If it's central nervous system, it's a transient ischemic attack, but we know transient ischemic attacks are never chronic. So if the patient says it's been going on for the last 6 months, 9 months, 10 months, we know it can't be a transient ischemic attack. It's more likely to be BPPV, okay, benign positional paroxysmal vertigo. So again, there are many maneuvers that you need to know how to make this diagnosis. It's a bedside diagnosis, the Tick-Salpike maneuver, as well as the Foley maneuver, which will tell you which canal is abnormal and which ear is abnormal. Okay, we don't have time to talk about that today, but there are a lot of references that you can look up in the internet, okay, and I've referenced it at the end for you to look up on how to diagnose this condition and how to fix this condition. Finally, the last scenario is a person who complains of vertigo, no central or peripheral features. It's going on for many, many years and months, but each episode is not transient. It's lasting very long. And I think many of you would have patients like that in your clinics. So what's that? Well, most of the time, that is not BPPV. It is not TIA because it's of the duration and the recurrent nature. It's most likely a spectrum of migraine. Okay, and so migraine is most probably the commonest cause of acute recurrent vertigo in young patients. So we need to manage this firstly by diagnosing it and treating it like migraine. And finally, all of us have patients like this. Okay, this is a guy who was just enlisted in the military, and after a trivial head injury started doing this continuously. Okay, so this is psychosomatization as a cause for vertigo. Now, this is an elephant in the room that we cannot ignore. Okay, so if I were to just stand in front of you now on this line here, okay, I have no problems, right? I'm not going to fall. But if I imagine now, if I go to the top of this hotel, right on the ceiling, on the roof, and I go to the edge, right at the edge, okay, same pair of legs, same pair of shoes, same cerebellum, same vestibular system. Why do I feel unsteady? It's because my mind is telling me I'm going to fall, I'm going to fall, I'm going to fall, I'm going to fall, right? So in other words, mind is a big component of vestibular system. So we cannot, as doctors handling the vestibular system, ignore vestibular system and ignore anxiety as a component. Okay, and I've illustrated the best way to fix this patient who's standing on the ceiling, if I'm standing there, is to blindfold me. If If I was blindfolded, I would be able to stand on the edge without falling, right? So in other words, if persons with anxiety, any underlying vestibulopathy would be enhanced tremendously. There are various names for it. There's a term in French called maladie de Bottemont, which is this vestibular dysfunction that occurs after disembarkation from a ship. But basically it is psychosomatization. So it's very important for us to address the underlying anxiety and bring the vestibular system back to its normal state of physiology. So, in summary, what did we learn? We learned the 4-question approach to dizziness, more for our own longevity, but also to help the patients. We talked about the usefulness of HINTS protocol to sort out the acute vestibular syndrome. We taught you briefly how to do the head impulse test, but you have to come tomorrow if you want to learn more. We told you, we introduced BPPV to you and referred you to the resources to learn how to diagnose and treat BPPV. We introduced migraine as an important cause of recurrent vestibular symptoms in young patients. And finally, we said don't forget anxiety. Now, finally, the thing that I didn't mention at all is vestibular therapy using drugs. Why? Because that is the biggest poison that you can ever give. So if there's one lesson that I want you to take home is, don't give patients vestibular medications, vestibular sedatives, whether it's metoclopramide or chlorpromazine, because these are medications to reduce your vestibular function. Here we are talking about disorders that are reducing vestibular function. So you want to enhance it by bringing on therapy and all that. So the more drugs you use, the more problems you're going to end up in the end. So don't use vestibular therapy unless you're dealing with an acutely symptomatic patient for the first few hours of his symptoms. With that, thank you.